So, greetings everyone. Welcome to the 256th session of the online Optom learning series OOLS. And for today's session, we have with us Dr. Chelsea Bray. Dr. Bray is a graduate from the University of Waterloo School of Optometry and Vision Science. She graduated in 2014 and currently she's also an assistant clinical professor at the same institute where she heads the Department of Advanced Contact Lens Services, as well as she is also involved in the cornea and contact lens residency as a supervisor. And herself, she is also a residence program finisher, I would say, because the residency program is a bit tedious in the US and in Canada, where she got an opportunity to work under Dr. Gina, which is a very well known figure, and she has done a lot in contact lenses and anterior eye by her research and her work. So she's going to take us through the understanding about the scleral shape and how can we use this information in fitting patients with scleral lenses. So welcome Dr. Bray onto our platform, and I will leave the screen time to you, please.
Great. Thank you so much for having me. We're going to talk a little bit today. It's morning for me. So we'll talk a little bit about scleral shape today. I have no financial disclosures. And yes, thank you for that introduction. Just a bit about me. I graduated from University of Waterloo School of Optometry in 2014. And after that, I did a 1-year postgraduate residency with Dr. Gina Sorbera, as you mentioned. After that, I worked in private practice for about 7 years. So as we're doing this talk and talking about kind of scleral profilometry, I was in private practice for 7 years, so I didn't have access to a lot of this technology. I'm very privileged now at the university that I do have access to it, but we'll talk a little bit today about the technology, of course, but also kind of working without it as well. And then that's my little fur baby there. As you can see, she giving me the side eye there as I'm working away on my computer. So we'll kind of have 3 parts today. We'll go over scleral shape and some lens fitting tips. We'll look a little bit at the scleral profilometry technology, and then we'll talk about some cases. So we know kind of over the past 15 years, there's been a dramatic increase in scleral lens prescribing. Dramatic. When I graduated in 2014 from optometry school, we had a bit of a lecture, I would say, on scleral lenses. And I remember in our contact lens lab, we had about half a lab on scleral lenses, but we only saw the lenses. We didn't even insert and remove them on each other. So things have really, really evolved very quickly. So it's an exciting time to be fitting these lenses. So the SCOPE study did a lot of work and found that kind of the main indications for sclerals was corneal irregularity by far. That's what most practitioners are fitting it for, followed by ocular surface disease. There's a number of conditions that can lead to very serious ocular surface disease that we treat with sclerals. And then lastly, coming in about 10% uncomplicated refractive error. So just high refractive errors, high astigmatism, those prescriptions that can benefit from rigid lenses. Most at this point, lenses are at least 16 millimeters in diameter. I find that there's a trend, at least kind of with me and with the clinicians that I'm working with, to fit a little bit larger than we have in the past. A little bit more landing zone to kind of evenly distribute the weight of that lens a little bit. So that's the trend that I've been seeing, at least in my fitting. And there's an increase in practitioners using more advanced landing zone designs. And if you haven't had a chance, there's an interesting patient and practitioner resource my big fat scleral lens that you could check out there, and the website is there. So just quickly, a little bit more of the prescribing trends. This is a bit of a more recent paper in 2023. Average lens diameter at this point was 16.2, a tiny bit larger than 16. And the indications were largely the same when they kind of resurveyed practitioners. So corneal regularity is still by far the most popular reason to fit these lenses. And then a little bit about the landing zones. At that point, spherical kind of comprised 64%, followed by toric at about a quarter, with quad specific and custom landing zones kind of fit the least frequently at that point. So just before we really dive in, a quick note about some terminology. And this terminology was adopted by the Scleral Lens Education Society in 2018. So when we're talking about the parts of a scleral lens, we have the three separate zones. So that middle optical portion that houses the refractive correction, and you can have a number of customizations in that zone. You can put front toric, front surface eccentricity to correct spherical aberrations. You can put custom higher order corrections now, a lot of research going into that. Decentered optic zones, multifocal correction, a lot of things that we can do. That middle region in between that optical zone and landing zone, called the transition zone, you will kind of hear it referred to as limbal zone or mid-peripheral zone at times. But this is kind of that limbal zone, and customizations can you can have multiple curves to kind of customize that limbal vault or mid peripheral vault. You can do quad specific limbal adjustments by elevation, oval limbus zones, things like that. And then we're going to spend a little bit more time talking about the landing zone today. So the part that actually rests on the conjunctiva and distributes kind of the weight of that scleral lens. So customizations for this, we can have toric landing zones, spherical landing zones, quad specific, custom. We can put notches, we can put vaults, fenestrations channels, a lot of exciting stuff to really kind of troubleshoot and get a really good custom comfortable fit for our patients. I'll share something. It's always learning with all this new stuff. Just last week, we had a low vision patient that we were fitting for severe ocular surface disease, no light perception in one eye, and very reduced vision in the other eye. Could independently insert and remove the scleral lenses, but had a hard time seeing the dot on the lens. And this was a quad specific lens, so had to be inserted in a certain orientation. And we talked to the lab, and you can put I hesitate to use the word notch, but like a very small flat portion on the bottom portion of the lens where the dot is supposed to orientate. So the patient can actually feel with their thumb how to orient that lens to put on independently. So that was something interesting. So you can do a lot of things. You have to talk to your lab, and you really have to troubleshoot for your patients. So majority of sclerals are still fit diagnostically currently. So by this, we mean kind of out of the diagnostic fitting kits. We talked a little bit about that landing zone. That's the zone that rests on the conjunctiva. It's very important that we get good alignment with the sclera in this zone. The landing zone impacts so much of the lens fit and the comfort of the lens for patients. So it impacts centration, suction, lens seal off, can contribute to midday fogging, compression, blanching, conjunctival prolapse, a whole bunch of things. So kind of well fit landing zones kind of we'd like them to be kind of lock and key almost on the sclera, whether they're toric or quad specific. They're very rotationally stable. And if we want to try and put any of those kind of optical zone customizations that we mentioned earlier, front toric correction, HOAs, multifocals, we want the lens to be very, very rotationally stable. So our landing zone can really help with that. So we have this scleral profilometry technology now, and there's a shift towards more custom fitting, maybe some empirical fitting, which theoretically should lead to improved efficiency, less chair time, fewer lens remakes, things like that. So landing zone, we're going to mainly concentrate on that today. We just actually had a scleral lens lab a couple of weeks ago with the students, and they're kind of inserting them on their colleagues for the first time. And one of them exclaimed, "This is like a sports drink for my eye, so refreshing." And I thought that was really, really cool and interesting that they immediately noticed that refreshing feeling of the lens and equated it to a sports drink for their eye. And then I just want to mention kind of here, although this technology is really nice to have, it definitely does not replace a skilled clinician with your diagnostic fitting set and a slit lamp. So those two things are not going anywhere. Um, and we recognize that not everyone will have access to some of this technology, and that's okay. I worked for quite a few years kind of without this and successfully fit patients, but it's what can we learn from this? And if you are getting into fitting more specialty lenses, to think about kind of investing in something that will pay off for you and your patients kind of in the long run. So there's a study here by Yoon in 2024, and kind of small, like I think there was about 15 eyes that they looked at, normal corneas, low astigmatism, and they actually found that using the profilometry did not significantly improve their efficiency compared with the literature on the average number of lenses ordered and number of visits. But this was kind of a small sample. Theoretically, it should. But again, just want to really make the point, like you can do a lot with your slit lamp and diagnostic trial set. So a bit of the basics. We know the sclera is a tough fibrous tissue. The collagen fibers are in a irregular orientation. So this is why it's opaque and not the collagen's not parallel like in the cornea, which is transparent. The conch to some degree is compressible, and we say it kind of acts a little bit like a cushion, and the scleral lens settles onto that spongy conjunctiva over the wear time. The the conjunctiva to some degree helps to offset any minor misalignments between the landing zone and the shape of the ocular surface. So it'll give you a little bit of a built-in error control mechanism. But we don't want to be relying on that. We want the lenses to be very well aligned to the sclera. So, good time to note, if we're going to be running any of this scleral profilometry technology on our patients, we definitely have to discontinue all scleral lens wear for a minimum of 48 hours prior to performing the scans. You can see kind of from this photo, there's a little bit of an indentation ring there. So this will affect the measurements, and you'll get not as accurate of a scan and lens if you order from that scan. Also, soft lenses. So any sort of contact lens wear should be discontinued before taking any of these scans. You do have to plan for this at times. especially those that are existing lens wearers are being refit can be difficult. So we'll definitely do one eye at a time, wear one lens, discontinue for 2 to 3 days. If they can get 72 hours, that's a little bit better for me, but 48 hours minimum. So yeah, we'll do one eye at a time. I find we do more of these scans on Monday is if the patient can be out of their lenses over the weekend. So this is true of eye impressions or running the scleral profilometry scans. Here, it's just an example scan that we took in clinic, and this was a patient who had not discontinued their scleral lens wear prior to the scan. So you can see kind of in the upper image um, that kind of compression ring on the sclera, and it shows up nicely in the tangent angles scan. We'll look at these maps a little bit more in depth, but you can definitely see kind of where that lens sat. So this would not be a good accurate scan for ordering a new lens from. So very important point, sclera is rotationally asymmetric. It's non-spherical. And the asymmetry increases with increasing radial distance. So the farther you out from the limbus, the more asymmetrical the surface is. So there's a few factors for this. It's likely influenced by differences in the location of extraocular muscle insertion into the sclera. Also, likely genetic factors in there, mechanical pressure from the eyelids. But the nasoscleral surface is flatter. The medial rectus inserts the closest to the limbus, about 5 millimeters away, and the temporal scleral surface is steeper. The lateral rectus inserts a little bit farther away as compared to the medial rectus. So increasing diameters of scleral lenses, you're likely to encounter more of this scleral asymmetry kind of as you get out farther from the limbus. So the scleral shape study group, some kind of pioneering stuff here, it came out in 2017. They found four kind of shapes of sclera that they were able to kind of classify into. And we can see here that only 5.7% had a spherical scleral shape. So of the subjects that they imaged and studied, that's only about 6% that would be successfully fit with a lens with a spherical landing zone. About 28.6 had a regular toric shape. 25% had something they called an irregular toric shape, so some semblance of toricity, but not exactly kind of 180 degrees apart. And the largest group at 40.7% had an irregular asymmetric sclera. So kind of to put this in perspective, only about a third of these eyes could be fit with a regular spherical or toric landing zone. The other 2/3 kind of had a more irregular shape and would theoretically need a quad specific or some sort of custom freeform scleral lens. This is kind of my representation of these categories. In soccer ball, sphere, soccer for us, anyways, in North America, only about 6%. So the take home from this is that not a lot of scleras are kind of spherical. So spherical landing zones are not going to work for us the majority of the time. It is still 6%, though. There are spherical scleras that exist, and you do encounter them every once in a while. Regular toric, so meaning like toric shape 180 degrees apart, kind of like your classic bow tie. Corneal astigmatism, 28%. Irregular toric, I represented that using a deflated football. We always talk about footballs when we're explaining astigmatism. So this one is kind of deflated. There is some toric pattern that the researchers encountered, but it wasn't 180 degrees apart. And then asymmetric, my dog has a kind of ball like this that bounces all around. So that was our biggest group, asymmetrical or irregular. So scleral sagittal height, it's lowest in the nasal area, where that sclera is typically flatter, and it's highest in the temporal quadrant, where the sclera is steeper. So when we're talking about this in terms of elevation maps, the nasal side compared to kind of a reference sphere is going to be more elevated compared with the temporal side. But then if you're thinking in sagittal height, sagittal depth, the sagittal height on the nasal side is lower than the sagittal height on the temporal side. And we know now that the sclera is more tangential in shape than curved. So we kind of want a tangent landing zone that really kind of aligns nicely with that sclera. So this is just a kind of point to just know what kind of map you're looking at. Um, Typically, when we're looking at these default maps from scleral profilometry, it always defaults to an elevation map, which helps us kind of with lens design. It's not defaulting to a curvature map like most corneal topographers would, like an axial curvature, something like that, which shows us about the corneal shape. It's looking mainly at elevation data. So the elevation maps are relative to a reference sphere. So hotter colors, reds, yellows, oranges. Those are representing higher elevation, but it's actually a flatter profile. So just careful when you're looking at that. Sometimes we think the hot colors are steeper, but in this case, it's representing a higher elevation versus the cool colors, the blue green, that represent lower elevation or like a deeper sort of depression to get there. So it's farther away from that reference sphere. And then just kind of in this example, in this figure, the kind of it's aligning with the corneal astigmatism there. Not always the case, but sometimes it is. So we did say this already, the greater the distance from the limbus, the greater the asymmetry and variability in that scleral shape, especially for irregular corneas. So when we're fitting these more larger diameter lenses, typically we're meaning like over 15 millimeters when you're getting into those like 16, 17, 18 millimeter diameters, you're much more likely to need a toric or quad specific edge design. So kind of the question is, how did we ever fit, spherical sclerals or toric landing zones previously with any sort of success? But that brings us back to the fact that the lenses do rest on the spongy kind of bulbar conjunctiva. So it allows a certain amount of forgiveness with lens design. So it helps to kind of offset any minor misalignments. But then we'll keep in mind that even if a sclera is asymmetric in nature, a toric landing zone is likely going to fit much better, even on that asymmetrical surface, than a spherical landing zone. So that's a good point to make. And then if we kind of look at this picture of a spherical lens on a toric sclera, and this is where kind of your slit lamp skills are going to come in handy. We can kind of see where there's edge lift towards that temporal part of the eye there. So sclera is steeper there. We're going to need to steepen that edge. You can really see that shadow. So if we had a scleral profilometry, we would be able to tell this, but really consider that when you put your diagnostic trial lens on, this is basically acting as your scleral profiler. And you can really be strategic about putting on spherical landing zones when you're fitting versus toric landing zones. We'll touch on that in a bit, but um, kind of your scleral, if you don't have access to some of this, your diagnostic set is acting as kind of your scleral profiler in this case. So you can use kind of putting the spherical and the toric landing zones to your advantage. Want to mention kind of the limbal zone here. On average, HVID, so horizontal visible iris diameter, does tend to be larger than VVID or vertical visible iris diameter. Not always, there's always exceptions to all of this, but I'm really recommending when you're fitting sclerals that you measure both of these. When the difference is about 0.5 millimeters or more, that's when it kind of becomes clinically significant. So you can kind of see from that photo, and that's an image from Daddy Fidel, who's done some work into looking at this, that if that lens, if you're using a lens with a spherical limbal zone, it's going to land maybe right at the nasal and temporal limbus, and or just inside it, and that can lead to kind of limbal staining, or you're going to get excess limbal clearance in the vertical meridian. Either case, we don't really want that and can lead to lens problems. So kind of it's very critical to ensure limbal clearance in all meridians. So you need to be assessing all the like 360 limbus around the lens to make sure you have clearance. Because failure to clear the limbus can cause significant ocular health problems and lead to also comfort and fit issues. Limbal staining, limbal stem cell compromise, conj prolapse, hyperemia, decentration, a whole host of things. So I do really recommend measuring both HVAD and VVID. There is some cases in the literature where corneas that have against the rule toricity, sometimes VVID is larger, but on average, HVID will tend to be larger than VVID. So why does this all matter? Why are we kind of looking into all this scleral anatomy and everything? Vaulting the cornea is really, I will say, that's more the easy part. You need a little more vault, kind of up the sag. You need less, lower it. It's where the lens touches the eye. That's where your patient's gonna start feeling it, complaining about it. That's the harder part, in my opinion. So it's critical to understand the shape of the ocular surface to do this. And I kind of came up with the 3 C's that the landing zone controls. It controls comfort of the lens. This is a huge one. If your patients aren't comfortable, they're not going to wear the lens, decrease wearing time, problems. It also controls centration. And we know that centration needs to be as good as possible and can be one of the hardest things to fix. But we need that lens to be centered for the most optimal vision and fit. And maybe a bit of a stretch with this C, but it controls conduct. So how that lens behaves, whether you're going to get conj prolapse, it's responsible at least in part for contributing to midday fogging. So the landing zone is very important. Improve comfort for patients if it's well fit, increase wearing time, improve quality of life. We want that for all our patients. Interesting picture there of just part of the landing zone, and you can see where that outer part of the landing zone, that outer haptic is pressing more on the sclera. So we would refer to this kind of as a toe down compression. So that outer part, if we think of the whole landing zone as a foot, that outer part being the toe, that's the part that's not aligning nicely to that sclera. It's compressing. So that's going to lead to some problems. So fitting lenses technology versus traditional, major difference. Um, the, the major difference is how you determine your initial lens order. Really, the rest of it, you're at your slit lamp, you're looking at the lens fit, you're looking at the eye underneath the lens, you're listening to your patients and their kind of symptoms. And then the rest is just looking and modifying or doing little tweaks. That's what I usually say to my patient. I'm just going to tweak things a little bit. Um, Whether or not you're using just your slit lamp or other technology like anterior seg OCT if it's available. So the point really is like use what you have, but know how to use it well. If you kind of have an OCT, by all means, it's very helpful for looking at edges, limbal vault. But again, I would say I did this for many years. It's not essential. Your slit lamp and your diagnostic fit set, you can do a lot with this, and especially with what we've learned from all this newer technology. Um, and if we're doing it from our diagnostic fit set, we're selecting that initial trial lens just based on SAG and estimating that mainly based on the condition that the patient has and kind of how advanced it is. So I tell the students, I'm like, if you're really good during that diagnostic fit, you should only have to put a maximum of 2 lenses on. Your first like best guess, and then sometimes that's good enough. You can do all of your fitting from that and just modify from that. Or if something's really off, we don't have enough sag and we're smashing the cornea, or we have way too much sag and we can't get good vision, then you should only have to put one more lens on to kind of correct for that major thing, and order your first lens off of that. Um, you can usually estimate the corneal geometry from the condition. So most of us would know keratoconus, we want a more prolate, kind of higher sag lens versus something maybe if the patient had RK, a more oblate shape. So I have some fitting tips that hopefully you'll find helpful from the literature. So when you're selecting the initial diameter of your scleral lens, you're obviously looking at HVAD and VVID, as I mentioned. A lot of the times the manufacturer will have a recommendation to work from, but you really need the landing zone of the lens to start outside of the limbal area all the way around. So really kind of know your fitting set, whatever lens brand you're choosing to work with. And a tip would be to find out what chord length that lens actually lands at. So not the total diameter, but the diameter at which that lens first touches down to that patient's eye. We want it to be outside of the limbus, ideally by about 0.5 millimeter, kind of all the way around. So an example of this, I've worked with Zen lens, say for a particular diameter of Zen lens, 16 millimeters. The initial landing point is at 12.8 millimeters. So then if I have scleral profilometry, I can look at this and calculate exactly kind of what is happening at that chord length diameter, or I can just use this to kind of select my initial diameter from my trial set. So if you're not sure of this, just reach out to the manufacturer. I think this is a really good, handy thing to know for the different diameters in your set. Where is that initial landing point that the lens is touching down? How wide is that? Typically, if the sclera exhibits less than 100 microns of toricity, we would consider it spherical, and a spherical landing zone will likely work. And this is where the conjunctiva helps a little bit with that offset. Um, Typically at a cord length of 15 millimeters or less, the majority of healthy eyes exhibit kind of about 100 microns of toricity. So this really comes into play with those smaller diameter scleral lenses. So tip is, if you're fitting a smaller one, try a diagnostic lens with a spherical landing zone first. So 15 millimeter and under lens, consider putting on a spherical landing zone, and then just observing the edges at your slit lamp. And this is going to tell you right away if you're going to need a toric landing zone or something more quad specific. If it's rocking, if it's moving, you're going to see it being tight in some areas and loose in others if you're going to need a toric landing zone. So consider putting on a spherical landing zone first for these smaller lens diameters. Larger diameters are likely going to need higher degrees of toricity in the landing zone, and often a quad specific design. So for these larger diameters, I would recommend applying a diagnostic lens with a toric landing zone. See kind of where it settles. You do have to let it kind of settle into place. See where those kind of toric markings are. Note that rotation, manually rotate it out of place and see if it rotates back to that same position. If so, the sclera is likely toric. If it doesn't rotate back to that original position, the sclera is likely not toric. So this will give you some information on that kind of quick and easy trick. As I said, measure both HVAD and VVID. Over 0.5 millimeters is significant. So if your lens has some sort of limbal customization that you could do, based on how the diagnostic lens looks on the eye, I consider widening the horizontal limbal zone or narrowing the vertical on that initial lens order. So I don't kind of wait to see if I get conj prolapse and decentration. If I have more excess vertical limbal clearance, I would just um, narrow that vertical limbal zone on the initial lens order to try and head off some problems. I always use fluorescein the bowl for the initial lens fitting. Time's going fast. Got a little bit more to get through, so I'm going a little bit fast here. Some more tips. So as I mentioned earlier, consider the landing zone as a foot. The heel is that inner haptic and the toe is the outer haptic. So good thing to do is look for heel down versus toe down landing zone. Where is that kind of blanching if it's too tight? Is it in the inner part of the haptic closer to the limbus, or is it right at the edge and when the conj is almost like bulging out? If you give this information to your lab consultant, they're going to be able to help you fix that lens, even taking photos, sending them to the lab. OCT, obviously here, if you have, this is an OCT we took of the lens edge the other day that I actually thought we did pretty good on. If you have that OCT, the edge should roughly settle about halfway into that conjunctiva. You're always going to get a little bit of it sinking in. I do believe we designed that lens using scleral profilometry, and so we got a pretty good fit, and the patient was happy in that lens. Few more tips. I always evaluate the landing zone in primary gaze. It can be hard sometimes to get, depending on the eyelid anatomy of the patient, to get them up out of the way. So there are times they might have to look slightly down, but you really want to be evaluating these lenses in primary straight ahead gaze, because it can alter things if they're looking up or down. And then we mentioned earlier being strategic about spherical landing zones, toric landing zones. You could consider putting, if you're putting on the two lenses, one spherical, one toric, and kind of comparing. try and use it to your advantage if your fit set has both of those types of lenses. And then I do like to put a little plug in for RGP lenses. Don't forget about them. They can be forgotten, but in some cases, can actually be the better choice for patients and not come with these kind of sometimes oxygen considerations, and midday things like midday fogging. So don't forget about RGPs. Fluorescein painting is something I do a lot. So when the patient returns after wearing their scleral lens, kind of for at least 4 hours for follow-up, I'll always see them after they're wearing the lens. Where does it get underneath that scleral lens? I paint it on the kind of by painting. I just mean I wet the fluorescein strip and kind of put it on the front surface of the lens, let the patient blink a few times, and then I usually only do one eye at a time. Immediately put them in the slit lamp, kind of wide diffuse beam. You can do it with white light. Sometimes blue light will be helpful here, and just start to look as they blink. Where is that fluorescein seeping under the lens? This is a really, really good tip for seeing if you have a flat edge, if they're getting midday fogging, things like that. Just kind of seeing kind of how that tear's pumping. Also seeing if none get underneath. I've seen that it kind of just stays on the front surface and absolutely none gets underneath. We have lens seal off. We know we really don't want that at this point. You're going to get a lot of suction. I start to worry about kind of oxygen over time. So this kind of painting the fluorescein, I do that every time. And the students know when they're working with me in clinic, they don't put on the fluorescein without me because I want to see what's happening when we put it on immediately. Where is that seeping underneath the lens? And then just basic things like if patients will always feel flat edges. So I'll sometimes just take the upper eyelid out of the way and see if that fixes their symptoms. If it does, the edge is likely flat, and that's something you need to fix. If the patients are comfortable, it's likely not a flat edge. Could still be tight. Tight edges can be comfortable at first, but yeah, just simply try to hold their eyelids out of the way. And if they're like, oh, that's way better, it's the edge of the lens is too flat. I'm going to skip over that for now. We know there's a lot of things, other things besides the scleral shape that can get in the way of our fittings. So we need to be working with lenses that allow us a lot of options. Lenses can get notches now, kind of micro vaults or focal vaults over an anatomical obstacle. Things like channels can do the same thing. And also there's an example of an impression-based lens there. So you want to work with a lens that has some sort of something to give you options to deal with these these little anatomical problems, we'll say, on this that we don't really notice pinguiculas a lot, but they can mean a lot when we're fitting a lens on that eye. Just quickly going to touch on kind of, is there a correlation between scleral shape and corneal shape? And this, if you only had access to a corneal topographer, like, can we infer anything from this? A little bit. There's still some questions around this. Physiologically, flat corneas usually correspond to flatter scleras in healthy eyes. So those with normal corneas. So typically we'd need flatter edges of the scleral lens. When corneal astigmatism is regular and over 2 diopters, there seems to be some correlation with scleral toricity in that same orientation. And this is especially when that astigmatism is limbus to limbus as opposed to central. And then horizontal asymmetry of the eye is greater than vertical asymmetry. This gradually increases towards the periphery of the eye. So most scleral lenses tend to decenter inferior temporal, and you're going to likely need a quad-specific design when there's significant lens decentration. What about in eyes with keratoconus? There are some studies that have found patients with keratoconus have more scleral asymmetry than healthy eyes, and the peripheral cornea and sclera are steeper in these cases. So eyes with very central ectasias, more similar scleral shapes to healthy eyes. So you can fit with regular kind of toric landing zones, but the more peripheral the ectasia gets, the more likely you're going to need a quad specific landing zone. And very kind of inferior ectasias, the inferior sclera is typically steeper. So tip in eyes with moderate to advanced cones, likely going to need a quad specific landing zone. And consider kind of in these moderate to advanced keratoconic patients, steepening the inferior quadrant on that first lens right off the bat to help you with that centration. So we got through all that. That was a lot. Let's look a little bit at some of the players in the scleral profilometry world where we're getting all this data from. So I have personal experience with the ESP, the eaglet ESP, and the Pentacam CSP from Oculus. There's two main types of these profilometers, reflection-based and then the Scheimpflug image. Reflection-based ones require the use of fluorescein to capture data because the sclera, unlike the cornea, has very poor reflectivity. I'm not really going to spend any time talking on the SMAP 3D. I know a lot of people that use it, but I have not worked with this one just simply because we cannot get these lenses shipped into Canada currently. So I only have experience with the eaglet and the Pentacam CSP. Just a quick comparison here between the two that I've worked with. The eaglet ESP, that's your reflection-based design. It is very fast. So captures a single image, you just hit it and it takes it instantaneously. 350,000 data points that can measure up to 20 millimeters of the ocular surface, but it is fluorescein dependent and tear film dependent. So requires ocular lubrication, a lot more prep to the eye. And it translates corneal and scleral curvature values into elevation maps. Versus if you look at the Pentacam CSP, that's the Scheimpflug imaging, rotates. It takes a little bit longer for the machine to rotate and capture about 250 images, measures up to 18 millimeters. An advantage here is that no fluorescein was required and it's tear film independent. The other good thing or advantage is you can repeat the imaging on the CSP and kind of improve coverage of a specific region without repeating the entire process. They do stitch together the images though, so sometimes I wonder a little bit about the accuracy of that. But having worked with both, there's pros and cons to both. The eaglet I find very, very good data from, but you really have to get the patient's eyelids out of the way. You have to have that ocular surface lubricated, and you have to have enough fluorescein where it's not draining out. So the preparation is key with that. Versus the Pentacam, you don't really need to do any of that prep. And you can stitch together images in some cases. So we get a lot of data. As we know, we can measure the sag at any single location or average over a specific chord length. So that helps us select initial sag of lens. It shows us the shape of the sclera, how much toricity and asymmetry, and where this lands. Is it kind of horizontal, oblique, vertical? So that helps you right away select your landing zone configuration. They will also identify any of those local abnormalities like pinguiculas that need extra vaulting or special attention. It's going to measure your HVAD, VVID, and it's going to give you your overall corneal geometry. So whether we're going to need a standard prolate lens or perhaps a reverse geometry lens. Kind of goes without saying, but truly, 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 if you're using these, garbage in is garbage out. If we do not get the patient's eyelids out of the way, it can be very time consuming. I'm working with students a lot. It does not give us, if we do not get a good scan, it's not giving us useful data to work with. I can just use my diagnostic trial lens set. So really, truly garbage in does equal garbage out. Um, and this is what we wish we could do with all our patients when taking these images for both. You really, 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 really have to get the eyelids out of the way. So there's different sort of tricks. We'll use cotton swabs a lot kind of to roll the eyelid up. There's also special kind of lid sticks for this. In my experience, it's always better with two people taking the scans, one kind of holding the eyelids, the other operating. But I do know people with technicians that can take them by themselves. You don't have to use anesthetic for these scans, but I do find it helps to kind of decrease that urge to blink so that they're better able to hold their eye open a little bit longer. These were just kind of some photos we took of one of our current residents, just demonstrating at the eaglet kind of how we have to hold those eyelids open. We'll get the patient involved in a lot of cases, kind of holding their lower eyelid. You have to really be careful to get that eyelid margin and not let that conge kind of palpebral conge flip up. And usually we find using something like a cotton swab or a lid stick and kind of rolling that upper lid up, especially for those patients with deep set eyes, works pretty good. This is an example of the interface on the eaglet, like the kind of data that you would get. This was a patient with a pretty kind of pronounced cone. Kmax was 83.7 on the pentacam scan. We ended up running this eaglet. We got good scans. She came and she was 2400 and we got her to 2030 with a scleral. The HVAD was a little bit larger, so we knew right away we'd have to go with a larger diameter lens, but this is the most common kind of map that will default. They call this the bisphere elevation map. You can see kind of off to the side all the metrics that it's measuring, and here's all of the different maps that we can look at in this kind of results tab. You can look at, show patients kind of the profile from the side. So that was that same patient. You can see kind of that inferior pronounced cone, and kind of you can even see here that steeper inferior sclera. So we would know from this that we need a very steep kind of landing zone in that area. This is kind of what it looks like. This is a different patient when you're taking the data, when you're taking the scan rather. There's kind of three areas that you are trying to get in the green: focus, centration, and corneal coverage. Coverage is good. You get a green here, but you can see in this scan, we don't have as much nasal scleral coverage as we do temporal. Eaglet is also not an automatic capture. You have to press the button when everything's lined up. And just an example there, it'll kind of classify the sclera for you into kind of one of those four zones just very easily at a glance. So you kind of know what kind of landing zone that you're headed for, which can be really helpful. Measures HVID, VVID there. Again, you can kind of see like we're trying to get those eyelids open in that picture. We probably could have done a little bit better in that kind of superior nasal area. And then this was just kind of show you the different screens. You can run, if I go back in the results, you can see there I can set to any cord length I want and get all of this data on sags, things like that. I can also go into first lens fit here for a scleral lens, and pretty much every lens manufacturer that I work with is compatible with this, and they all have algorithms that will just automatically take that data and calculate either the lens to order or the best first trial lens for you. So you can see there, just as an example, we've selected Zen lens with a diameter and put in the apical clearances that we'd be aiming for. And it does kind of spit out the sagittal depth, the base curve, and the edges that we'd be looking at. So just flipping through this, and then this is an example of the Pentacam CSP printout. So same data that it's showing us, just a different way to kind of present it. There you can see the Scheinfeld images. It does have to be very dark when taking these. And in this one, I'm just trying to see, yes, as I'm moving closer, you could see these dotted areas here. That's where we perhaps didn't get the most coverage. You can see we're missing a little bit on that coverage map in the upper right-hand corner. So that's where it's kind of stitched the data together. And then this is an example fitting guide from the lab for the eaglet, just kind of in contrast, the Pentacam versus the eaglet there, sorry, on the right. And basically they give you an algorithm, what to set the cord lengths at, how to calculate how much sag, how much toricity. It's very stepwise and logical, which is very helpful. This is just another example for the Pentacam CSP with another lab. And then, so there's three main ways you can fit from all this data. You use it as a starting point and select the closest trial lens in your fit set, and then you would over refract and use your slit lamp for adjustments. You can order it empirically using the predicted lens parameters, or using those algorithms that I just showed you, you can send it directly to the lab. This can be useful for more extreme parameters if your diagnostic kit doesn't have close parameters to what you are needing for that patient. And then this is especially good time-wise if the patient was already in rigid lenses. You already have that over refraction data on a known base curve, so you could skip putting a trial lens on completely in this case. The third way is you export the entire file into a custom design software. I've worked with ScanFit Pro a bit and Wave to completely customize and design that lens for complete control. I would be remiss if I didn't mention kind of impression-based fitting in this technology section. Impression-based fitting was introduced around 2014 with iPrint Pro. We started working with it at Waterloo last year. And I will say, kind of for some of these hard to fit patients, or actually any patient with a glaucoma filtering bleb, I'll go straight to this. It does work very well. You can see I'm getting it on my eye there. You don't even need anesthetic for this. I wanted to feel what it felt like. And then we took a photo at the top right there of two of the lenses we ordered. One was for a glaucoma filtering bleb there on the right, and the other was a very, very deep sag that we couldn't fit with any of our diagnostic fit kits. So I just running out of time, I know. Hopefully we have a few minutes just to look at a couple interesting cases. So this is an example of one I fit kind of with the eaglet, 48-year-old female, post-DULCs. She had post-LASIK ectasia. She was in RGPs, but poor comfort, lens would pop out. She was from about 2 hours away from our clinic. So time was of the essence. Kind of some initial presenting photos of the eye there. But we wanted to be as efficient as possible for this. So we went ahead and did eaglet scans at the first visit. The patient was currently wearing RGPs, which may affect the corneal data a little bit, but we went ahead and did the scan because she wasn't wearing soft lenses or sclerals that were landing on her sclera. So we thought we could get fairly decent data at that first visit. You could see with the right eye, kind of it's predicting a toric landing zone there, but we did kind of in that upper nasal, that seems to be the problem area for holding eyelids open, get a little bit of eyelid in that area. That also, that small little circle is indicating some sort of localized elevation. I believe she had a small conjunctival cyst in that area. So we ended up just running the first lens fit software and selected the closest trial lens in our fitting kit. Working with students, I do tend to do this. We'll kind of always typically put on the diagnostic lens that's closest to that and do our at least our over refraction, but look at that lens on the eye and see how it's fitting. We achieved this fit in only 2 lenses, which I don't think would have been possible without some of this scleral profilometry data. So ended up getting very good vision, 20/20 in each eye, fit only in 2 lenses. The initial ones we ordered and 1 revision, and one of the eyes was, I believe, only a power change. So here's some of our anterior seg OCT images. We just got the new Anterion anterior seg OCT, so take some really great resolution images for us. You can obviously tell one eye's had cataract surgery, one eye has not, but the lenses after settling, you can also see between these two that one lens has a much more prolate shape and the other ended up being more reverse geometry. Even though she did have the bulk in both eyes, they were significantly different shapes. Case 2, we ended up doing with the Pentacam CSP. This was a case, it was a university student, relatively normal corneas, just high myopia, high astigmatism, but very dry eyes. Not happy in her previous soft toric contacts, unstable rotation. So you can see she does have some high myopia there and just wanted another option. We initially did the fitting just with diagnostic fit sets and count them. We were at 4 revisions later, still not a good fit. There was a tiny little bit of movement of the lenses. We couldn't seem to align with the sclera no matter what we did, getting midday fogging, discomfort, patient not satisfied. This is kind of the worst case scenario when you can see here, I'm sure you've all encountered this kind of revision after revision after revision. So after a few, we were like, okay, we washed her out of the lenses. This is just her pentacams here, just showing her corneal astigmatism. And then we got fairly good CSP scans with minimal extrapolation, and we followed the algorithm. We actually specifically went to the CSP in this case because this patient with the dry eye, the fluorescein just drained like crazy. So ran that, and here's just a comparison kind of the lenses that we had her in and then what the scan predicted. To be honest, it's not crazy off. A little bit of flatter base curve, sag a little bit different, and edges were different. But what I can tell you is with the first lens with the CSP, much better alignment. And here's where the original lenses honestly did not look that bad at the slit lamp. And so this is where scleral profilometry can really be invaluable. We just could not seem to get that alignment. And so final order on the first lens that we ordered and was able to wear 10 hours comfortably with minimal midday fogging. So I know we're kind of at the over the hour mark. So I'm just going to show you, this was a recent case, patient with graft versus host disease. And severe ocular surface disease from that, and actually has a prosthetic eye from 4 failed corneal transplants. So is monocular, but due to ocular surface disease and some severe corneal thinning, the corneal specialist was considering a torsorrhaphy, but best corrected VA was very variable, about 2100 with refraction. So we did kind of pentacams a mess there. This fluorescein photo, we tried to show that area of thinning, but we did end up doing eaglet scans, eaglet ESP scans, and got a pretty good fit. We were also in a time crunch for this patient because they were leaving for Florida in about 2 weeks, escaping the Canadian winter. And you can see that kind of area of severe thinning. Obviously, we have higher vault over that area, but the point is that the profilometry really helped us out, especially in these cases when we're in a very big time crunch. So I think I will end it there. Thanks for listening. And if we have time for questions, happy to answer anything. But thank you so much for kind of your attention and hanging out with me today.
Thank you so much, Dr. Bray, for that very comprehensive presentation. I think the sclera is not taught well as well. I mean, when we were studying ocular anatomy, we never knew that sclera is so asymmetric. And now with the advancement,
Yeah.
thankful to the advancement, we now know that how the sclera can make our life difficult when we fit scleral lenses, right?
Yes, it can make it difficult. Yes.
Yeah. But thanks to the technology, we now know that whatever we probably would have done 10, 15 years back was just to give the vision, but we know that most of the patients were not comfortable as they would be with the lenses we
Right.
can give them today, right? Yeah.
Exactly. Yeah, exactly.
Wonderful. Great. So I think the other part of the discussion is nowadays we do have scleral lenses, the trial diagnostic lenses itself, they have the toric as well as the spherical haptics lens. I mean, that's something which is great. It's coming up. It's a bit rare on this side of the world in Asia,
Okay.
but I think we are getting there. And your tip for just put the toric lens and see if the rotation is there. If you don't have any scleral profilometry, just that evaluation can help you a lot, right?
Yeah. That's exactly right. I find in the fitting sets that we're working with, the majority of them now will still include both. Some have moved to only having toric landing zones actually, but
Okay.
the majority of the fit sets that we work with will still have some spherical and some toric with the same sag. So it's helpful and can give us options kind of when we're fitting from that diagnostic fit set.
Yeah, right. Now, as we know, only 6%, if I remember the slide, only 6% of
Good
these
job.
scleras are spherical. So
Spherical. Yes, that's what the scleral shape study
is
group found
right.
there. Yes.
Wonderful. And I think somebody wants to know about if you have an experience using an
Okay.
OCT to kind of look at the lens. Any thoughts over this part? Yeah.
That's a really good question. I actually, well, I went over with my presentation anyways, but I think there was a slide hidden with this heading on that I didn't end up getting to the corneoscleral junction and kind of how that contributes. So there's some interesting literature on this that can help choosing this. Like, is it a which area kind of the sclera has a steeper versus like lesser angle, and kind of what that means like for the slope of the sclera in that area. We're actually, I mentioned we just got that Anterion OCT, anterior seg. So we're kind of starting to look at this a little bit more, but it definitely contributes. So I will put a little bit more about this in a future presentation, but it definitely contributes. That's a really, really good question. Um, yeah. And then I
Wonderful.
see oh, you put them up. I see how this works. This is
Yeah, it's on the
nice.
screen, so you don't have to worry of the chat. Yeah. The,
Yeah.
the other question is, using scleral profilometry, is it much better to fit the lenses for ocular surface disease patients versus corneal ectasia patients? I mean, where does it work the best?
I that's a good question. I do tend to find, just in my experience, that some of those severe ocular surface disease patients can be, I mean, even sometimes when they have, quote, like normal corneas and more normal scleral profiles, they get a lot of problems with midday fogging. There's just so much baseline inflammation in those eyes. So I will tend to use the scleral profilometry more in those cases to just try and align initially as well as I can. Um, a lot of the times, we still get some degree of midday fogging in these patients, but at least I know I'm doing kind of everything that I can from the get-go to try and get that really nice tangent alignment so that the edges aren't contributing to any debris getting caught up under that lens. Can definitely be helpful in ectatic disease as well. But yeah, I will, some of those ocular surface disease patients I find a little bit tougher. And then, of course, other problems like wetting at the surface of the lens and everything. But yeah, I definitely tend to, I think, kind of use it a lot more in those patients right now.
Right. And this is more to do with, the protocol of, the evaluation when the patients come for aftercare. We do know that applying fluorescein might have some effect on the vision. So is there any specific
Mhm.
protocol where you do the vision assessment first and then go for fitting? Or is it
Yeah.
something you would like to, comment on?
Yeah, I definitely do it after we check the VA and do the overrefraction. So when they, we dispense the first lens and they come back for their first progress check, typically we'll always book those kind of in the afternoon so that they can wear that lens for minimum 4 hours, so it's kind of settled more into that conjunctiva. So we'll check vision first, do the over-refraction, and then I typically will go to the slit lamp first without fluorescein, and just observe what I can there and do OCT if I need to, and kind of yeah, as a last step before I take that lens off to evaluate the eye underneath the lens. That's when I'll put the fluorescein um, on the like painted on the front of the lens, and then put them in the slit lamp to see kind of where it's getting underneath when that lens is fully settled before I take it off. During the like initial fitting, I do dip the fluorescein in the bowl. Like, when I haven't found it to be a super big detriment to kind of the VA on that initial lens fitting. So I don't often find that we have to kind of remove the lens to recheck VA without the fluorescein. But definitely when they come back, yeah, we'll do the over-refraction without and check the VAs before applying painting that fluorescein on the surface. Yeah.
Yeah, great. And I think one more question, this is more of fitting related, perhaps, when you have a patient who has this rings when the lenses are removed. So perhaps referring to any
Mm, yeah.
indentation and things like that. What are your thoughts? What would be the to-go thing to modify? Is there any to-go in the first place? And if yes, what do you want to modify?
Yeah. You definitely will see these rings when you take it off. I kind of sometimes you can always tell that there's something on the eye, but I mentioned I'm kind of trying to fit a little bit bigger. So I do find I will get these more with smaller diameter sclerals. And it's just kind of like there's less landing zone to distribute the weight on, I find, for these patients, and more like not exactly like a knife edge, but more like there's just less area to kind of distribute the weight on, and it tends to dig in more. So um, fitting a little bit bigger, I find. So I'm trying to fit as big and with the edges as flat as I can without getting discomfort and midday fogging, to just kind of try to just rest on that surface and not dig in a lot. So I would recommend going a little bit bigger diameter if you're getting these, because you will get a lot of suction, I find, uh, when you're seeing these indentation rings. And I'm seeing more like with my patients, suction, there's no tear exchange. That's much worse for oxygen. So seeing a little bit more corneal swelling kind of in these patients with more suction, which I'm trying to kind of move away from. So kind of fitting larger, and then yeah, you may have to kind of flatten a little bit, but you can only flatten so much with those smaller diameter ones. So, if you're getting problems from flat edges, then definitely going bigger, I would recommend. Yeah.
Wonderful. Great. Yeah, I think with that, we have taken all the questions on the chat. Thank you so much once again, Dr. Bray, for that
Great.
wonderful session. I do
Thank you
appreciate
so much
you
for having
sharing your
me.
time.
Yeah.
Yeah. Thank you so much for sharing your Sunday morning with us. So
Yes.
appreciate that. Yeah.
Thank
To
you
the
so much. And thanks
attendees,
to everybody. Yeah, who came.
most welcome.
Appreciate it.
Yeah. We do have session planned and we will share more details about the future sessions onto our social media as well as onto your email. Until then, take care, be safe, and I hope to see you during the next session. Have a good day. Thank you, Dr. Bray.
Thanks.
Have a good day.
Bye.
Bye.
You too. Bye.